I'm fascinated by bed hold, and I love to talk about it. Some states have used triggers on their bed hold with occupancy, so you only get a payment if you're up above 95%. I really like that as sort of a rider. The problem is I think that's very difficult to enforce. In New York State, my colleagues there shared the information. They had never enforced their bed hold. In terms of, they'd always just paid it. They had never checked, I should say. They had never enforced or checked this threshold. So even though in the books it said you have to have 95% occupancy, they weren't actually going into the cost reports, actually auditing the facility, making certain they were above that threshold. So I think there are ways of targeting bed hold to make certain if you're at an 85% occupancy facility, you're hospitalized, I think there's going to be a bed there. If you're at a 100% occupancy facility, maybe the facility does deserve a bed hold payment.
But if you're talking about the long-stay nursing home resident, have you factored in the fact that that's their home?
You know, absolutely, and I think these are the sorts of trade-offs one needs to make. It is their home, and should they be hospitalized from their home? You know, unduly. I think these are the sorts of trade-offs. You're trading off sort of being displaced from their home versus I think something equally traumatic, which would be being hospitalized from their home. And
no, I mean returning back to the same.
That's what I mean. Absolutely, you want to trade off this continuity of care in this environment from being unduly hospitalized from this environment.
If you repeal the bed hold, then you're right. I'm assuming that you're not going back to the same place, but there's certainly no guarantee they're going to the same place.
There's no guarantee, but I think that there's a lower likelihood of them returning to the same place. According to our data, it's slight relative to, there's also a much lower likelihood that they're ever going to be hospitalized in the first place. And so I agree with you. They're two sides of the issue, but trying to trade off the tension between the two is important. And our view is when taken together, you'd be better off repealing bed hold, or at least making bed hold, modernizing bed hold such that you're enforcing the thresholds. You're not paying indefinitely. You're trying to target those dollars more effectively. Marion's dying to get in on this guy.
Well, our data show that what Sandy's suggesting is true, that when you decrease the number of days that beds held for, you will get fewer people coming back. But I think there's another factor that's very, very important, and I don't know that anybody has really studied this aspect, and that is because of relocation stress and iatrogenic illnesses that people pick up consequent to the hospitalization may have done them a real disservice, because that is a very serious consequence. And I don't know anyone who studied the financial costs of people coming back at a higher level of drug, case costs, or the cost of those people if they go to another nursing home and then are also sicker. Even if they come back to the same nursing home and they're sicker, maybe they've kept their home but at a very high price.
Yeah, I think that's been a hard issue to target, largely because of the selection of who's hospitalized and who's not. It's non-random, and so finding that really good comparison group of who do we compare those hospitalized with, those treated in the home for pneumonia versus those hospitalized. But I totally agree with you. It'd be really interesting to sort of play that out. The sort of observational studies that are out, you're never going to get a randomized trial around this, but the observational studies do suggest exactly what you're saying, that there, lots of bad things happen in the hospital, and you want to avoid those, and there's a big financial cost. And I'll just note, I've had this idea that distance is a well-utilized instrument in the health services literature, and I've always thought about, is distance between the nursing home and the hospital a potential instrument here that you might have a stronger propensity, ceteris paribus, to hospitalize if they're connected, if there's if they're closer than if they were farther away, or some measure like that may be an interesting way of sort of introducing some variation here. But actually, exactly these kind of financial ties. Yeah.
I was doing some qualitative analyses in Texas of nursing homes and prisons, and one thing I noticed in both is that prisoners, for example, if they went to the hospital, they lost their cellmate, their cell and cellmate, and that was actually a critical thing, and they wouldn't disclose illnesses. And same with nursing home residents. It seemed like, losing not the nursing home itself, but even just they wanted to go back to the same room, and they weren't guaranteed that, and that created resistance to being hospitalized. But the other thing is that we were trying to do a telemedicine project there. We did, but the whole thing was designed for evening hours when they're short shift.
I think liability is a big part of. I was expecting someone to ask why the increase in hospitalization costs. I think liability definitely plays into this. And just to pick up on another part of your comment, undoubtedly, one of my colleagues in New York State loves to talk about the 3 a.m. call and the 3 a.m. send down to the ER and the hospitalization. A lot of things happen in those midnight hours. And for those in the room that study nursing homes, we don't have a 24-hour RM presence in the facility, and not to mention any kind of nurse practitioner or physician and so on. There's lots of hospitalizations that might be prevented with, stronger around-the-clock staffing. Is there another? Yes.
Since you have done so much research about this, what is the current government's approach as far as for Medicare to support the Medicare nations are doing Plan A, B, C, and also as well as Plan D, or the Medicare supplement that is going to be prepared by a private company? What is the government doing?
Yeah, there's a lot of ways. I'll talk a little bit more in kind of the solutions here about sort of, I think, better targeting some of the dollars with capitation in this area, where I think you can sort of blend some of those payments. Medicare Advantage has been sort of a mixed bag over time, and so I think there are a lot of sort of classic ways of holding down costs, but for this particular problem, I've been particularly intrigued with capitation. So I want to say I'll save those remarks and say a few words about kind of how we might sort of offer blended products, blended Medicare Medicaid products, kind of try to correct some of these disincentives, but recognizing, and I think what you're suggesting is the problems with Medicare go far beyond what I'm talking about today. There are plenty of examples of SNF rehospitalizations, which are largely a Medicare problem, lack of case management, poor primary care. We could go on and on. Medicare needs to be fixed beyond what we're talking about here. But just to try to keep on this topic, let me save that and talk about capitation. Other. So moving to another example, away from hospitalizations from nursing homes and hospitalizations from Medicaid home and community-based services, this is a really nice study by Glenn Mitchell and colleagues. Larry, were you one of the co-authors? Yeah, somewhere down. Larry was on this as well. I really enjoyed this and perfectly encapsulates many of the ideas that I'm talking about today. And sort of trades off a Medicaid home and community-based services HCBS contractor here in Florida. As I understand the program, and Larry can correct me on the details here if I've gotten any of this wrong, but the HCBS contractor is responsible for paying, when a beneficiary is hospitalized, the contractor is responsible for only the Medicare deductible and copays, whereas Medicare pays obviously the bulk of the hospitalization costs. Trade off that against an individual isn't hospitalized, Medicaid, the contractor is only is responsible for the full cost of care, and that can be quite expensive in some instances, such as respite care. So you get this very perverse incentive where low cost and high cost settings, but it's cheaper for the Medicaid HCBS contractor often to ship the individual to the hospital. Clearly, that's a bad outcome for the individual, and sure enough, that's exactly what Glenn and Larry and colleagues found. There was quite a bit of cost shifting to Medicare in terms of increased inpatient hospital days. And what's particularly, I think, problematic about HCBS, and this comment I think is broader. So this, I'm not certain every HCBS contractor works this way in other states and other programs, although I know some that do. That's not necessarily true everywhere that they have these kind of perverse incentives, but certainly here in the Florida program that was the case. I think a broader issue is that oftentimes in HCBS, the case manager doesn't necessarily follow the enrollee into the hospital or the SNF, even if that's a short stay in the SNF or a short stay in the hospital. You would think that's exactly where you most need case management, in the hospital, in the skilled nursing facility, and yet case management sort of ends at the door. That doesn't sound like case management to me if you're not sort of covering all kind of scenarios here in the care. That's obviously suboptimal, and it's going to lead to the situation where there's a much higher probability the individual isn't going to come out of that SNF